let's make sure everybody's on the same page about this stuff. Your last quiz is due, I can't remember what time. It's either tonight or tomorrow sometime, so go ahead and get it done. It is reproductive. Okay, so we're going to finish it today. You will have had it in lab anyway. I have regular office hours this week, and then on Friday, I have office hours 9:30 to 3 on Redwood campus. That's the last time you can look over anything, but you can look over everything, including the test that you take on Wednesday. I'll have the bubble sheets there on Friday, so you can look over if you got anything wrong. I can't guarantee you that I will have the short answer graded on Friday, but I'll have it graded probably at some point on Friday, right? So, especially for you guys. So your test for is December 5th. Remind me what it covers. Blood, vessels, urinary, reproductive, right? Good, that's what that one covers. And then your final is Monday, December 10th, 1:30 to 3:30. Okay, it's 100 questions, all bubble sheet, no bonus. It has to be done really quickly. So I'll probably can grade it for you when you leave, right? I can just take a picture of it and get it graded for you when you leave. So for those of you who are on the fence or might not have to take the final, that has to be on you because the lab grades will not come to me before Monday. But you can get your lab instructor to get yours graded if you are very kind and offer treats, for instance, then they'll get it done for you. So you should know your lab grade even if I don't know your lab grade. And you can add them up, right? You can do that. I know you can. Okay, just like pretend like you stick it in the Canvas thing and see what the grade does, right? So I won't have those on time. So I will tell you that since you guys have your final on the first day of finals week, I will get your grades, your test score done as soon as humanly possible. So last time I got them done in a day. If you guys leave me alone and don't come ask me questions that you already know the answer to, then I will get them done really, really quickly for you. Because the people who have their test on Thursday can wait a little longer, right? Okay, what was your question, Alice?
So, and you said that we don't have to have our cumulative grade has to be an A
Yes.
before we take the final. So
Yes.
we don't necessarily have to have an A in lab.
No.
As long as the cumulative is an A.
Right. And not dropping anything. I want to remind you that if you're going to drop the final, you don't get to drop anything else, right? So if you add all of your test grades up and then divide by whatever, then if it's an A, 92.5 or higher, then you can stay home and feel good about your life decisions. Good? Okay? All right. So, so we are going to finish the female reproductive tract and then do male and then just talk about the stages of sexual response today. Okay, so I think that we were on ovaries, right? But we were on tissue layers of the ovaries. Does that sound right? So we already kind of talked about blood supply, homologous to the testes. Somebody nod or shake your head. Yes? Okay, good. All right, so if we look at the tissue layers of the ovary, if we actually get into the ovary specifically, it's pretty easy. The outer layer of the ovary is basically an epithelial tissue, and it's like in contact slash continuous with the peritoneum. Okay. The outer layer of the ovary is called the germinal epithelium. And the reason that that matters is because that is the site of ovarian cancer when it occurs. And we'll come back to that in just a second. Just deep to that is the tunica albuginea. This is connective tissue. You have to bust through the tunica albuginea and the germinal epithelium during ovulation. And then if you keep going deeper, this is the ovarian cortex. That's where all of the meiosis and ovulation action happens. Yeah? And this is the ovarian medulla. Really all that happens there is tubes and nerves coming and going. Okay? So I want to briefly take a minute and just talk about how this whole meiosis and ovulation process occurs. This is really oversimplified, but I want you to at least have a picture of what occurs. Because Alice asked about this last time. So you've been told many, many times, and I was too, that women are born with all the eggs that they're ever going to have. And it's not exactly true. It's like truthy, but not exactly true. What you are born with is all of the egg-producing structures that you're ever going to have as a woman. Those are called primordial follicles. Those have 46 chromosomes. You have 1.5 to 2 million of those. Even in Utah, ain't nobody planning on having 1.5 to 2 million babies, right? You typically ovulate about 400 of those during a typical woman's reproductive lifetime. The rest of them are just degenerated. It's called follicular atresia. But in a normal cycle with a woman, what's going to happen is one of these will start going through meiosis and maturation. And the meiosis process, of course, is happening primarily with the chromosomes. We're reducing 46 chromosomes to 23 chromosomes, right? Okay, meiosis 1, meiosis 2, I don't know if you guys remember that, but anyway. So you're going through the process of reducing chromosome numbers, but you're also developing this big supporting follicle that supports the development of this guy. And also it ends up developing a whole lot more really, really rich cytoplasm too. And then of course, what's gonna happen is this is going to get to the point of ovulation, usually under the influence of high levels of progesterone, and then ovulation is gonna occur, right? You with me? And then it could take a weekish before implantation could occur in the uterus, right? So what has to happen is this structure that was the follicle, used to be the follicle, actually stays around for about a week and continues to secrete progesterone just in case implantation occurs. If implantation doesn't occur, it's like, oh, no longer need to make any progesterone, then you start the whole damn thing over again with the next cycle. Does that make sense? So generally, with most women, you go through meiosis and ovulation with a single one per cycle. However, of course, some women and some some genetic predispositions, ethnicities, I don't know what you want to call them, I don't know what the word is there, have a predisposition to hyperovulation, meaning that you're more likely to go through more than one per month. And then as women age, as you get into your 30s or 40s, like I am, make sure your birth control is working, because as you're at the end of your reproductive life, women tend to hyperovulate. So you will be more likely to have a multiple pregnancy and multiple birth as you age, which just scares the living hell out of me, I gotta tell you. I have a friend, my friend Kelly is my age, and she has an 18-year-old daughter and a 16-year-old daughter. Now she has 3 8-month-old baby triplets. And she came and told me, and I was like, congratulations. I don't even know what to say with that. And they weren't using anything. They weren't even like trying. They just she just got knocked up with 3 little baby boys. It's bonkers. Doesn't that scare you moms to death? You're like, oh my God. Can I have 2 IUDs? Can I have 2? Let's do a 2-for-1 sale. Let's stick them both up there. Okay. So here's the deal with women, as we mentioned last time. The issue with women and improper meiosis and the increased likelihood of, for instance, chromosome abnormalities like Down syndrome and Turner syndrome and all of the those are all meiotic problems in which meiosis doesn't happen normally. And they increase in likelihood as your follicles age with you. So whereas I can't remember the exact statistics right now, but I've got it almost right. Whereas if you're like 22 and you have the likelihood of, for instance, a chromosome abnormality like Down syndrome is something like 1 in 2,500, okay? But when you're my age, the probability of chromosome abnormality is about 1 in 16. So, because they age with you, right? And with men, they don't age with you for reasons we'll look at in just a second. Okay, so the medulla, as we already talked about, just basically connective tissue with tubes coming and going from it. All right, so as far as the supports for the ovaries, what is holding them in position? You guys did this in lab, so it shouldn't be unfamiliar to you. This is the ovarian ligament. It's not a tube, it's a ligament, and it holds the ovary to, for instance, the uterus. And this guy, even though it's drawn weird, this guy right here is called the suspensory ligament, and it suspends the ovaries from the body wall, and that's also where the ovarian artery and the ovarian vein run through, right? Meaning the gonadals, right? Okay, and then the broad ligament. The broad ligament isn't really supporting the ovary, but it's like behind it, right? It's behind the ovary. It's really more of a support for the uterus than it is for the ovary, but it's back there anyway. Okay, ovarian cancer. Let's just briefly talk about ovarian cancer. Ovarian cancer is the fourth leading cause of cancer-related deaths in women. It's not as common as breast and cervical cancer, but we don't usually catch it as early because, like I said, it quite often occurs in the germinal epithelium. And then what it does is it just irritates your peritoneum, and the peritoneum irritation manifests as like, oh, my stomach hurts, or oh, I feel like I have cramps, or oh, something that doesn't tell you that you have ovarian cancer. So unfortunately, that means that the diagnosis is not likely to happen in the early stages of the cancer, but more likely to happen in the later stages of the cancer. And that's why it's more likely to kill a woman. So, but it does have a pretty strong genetic component. So I just want to go ahead and reiterate that if you are a person who has a family history of breast or ovarian cancer, then your care provider needs to know that. Because of course you would take a stomach ache far more seriously from a woman whose aunt and sister had ovarian and breast cancer. And by the way, ovarian and breast cancer can be the same genetic predisposition manifesting in two different ways. So they need to know about both of them, okay? Okay, so now let's do the fallopian tubes or oviducts or uterine tubes, and they're here. Okay, so here's how those work. So if I'm a uterus, right? These are my oviducts. They fold out and over, and then my ovary is right there, right? Do you see? Okay, so out and over. And what happens is ovulation occurs, and then they're going to go up and in, right? So it's kind of a weird little path. So let's just look at the parts. The blue portion that folds over the ovary is called the infundibulum, and it has these little fingers on it called fimbriae, which means fingers. By the way, it really folds over only in high progesterone situations. So it's just like hanging out, and then if your progesterone gets high, it goes to try to make it more likely that ovulation will occur into the tube. Does that make sense? Okay. All right. But it's actually not attached, FYI. Then the ampulla, the yellow portion right there, is where most fertilization events occur. Way out there. Okay. And then the isthmus is the green portion as you're moving in, and then the uterine portion. If a tubal pregnancy occurs, it's usually going to occur in the isthmus because the uterine part is hard to get through. Does that make sense? Okay. So as far as the tissue that makes up the oviduct, you guys probably remember on the outside, it's basically going to be the serous membrane, like visceral peritoneum, right? Some connective tissue, smooth muscle in the wall. And the smooth muscle in the wall is going to help with what we call the courting of the oocyte, which is when you ovulate, it should really contract to pull things sort of in, okay? And then do you remember way back from the beginning of the semester that your uterine tubes are lined with ciliated simple columnar epithelium? Does that sound vaguely familiar? Okay. And so again, under conditions of high progesterone, what's going to happen is the muscle's going to contract and the cilia are going to wave. This is called the courting of the oocyte to make it more likely that, of course, the ovulated oocyte is actually going to get in. Does that make sense? And apparently it works pretty well, right? There's a lot of us. It's all right. It's doing okay. Okay, so, all right, so clinical notes. So pelvic inflammatory disease. Pelvic inflammatory disease is when something irritates your reproductive tract. It usually, of course, makes it into the reproductive tract via the vagina, right? And then it goes up into the cervix and perhaps the uterus. But the problem, a lot of times, not always, is that these are so narrow that if you scar them, you are going to have fertility issues. Does that make sense? Okay. And unfortunately, with pelvic inflammatory disease, you don't have to have known that you were ever infected for the scar tissue to have built up. So it goes from the vagina into the tubes, can make it into the peritoneal cavity. The most likely causes of pelvic inflammatory disease are STIs like chlamydia and gonorrhea, but you do not even have to be sexually active in order to get pelvic inflammatory disease, because you could have just had some opportunistic infection that made it in there, right? Or you could have a woman that, of course, doesn't know how to wipe properly, and then you can get pelvic inflammatory disease. And, of course, the problem is that it is one of the leading causes of infertility, because if you end up blocking one of your tubes, you've reduced your likelihood of having an implantation by about half. Go ahead. I'm about to cover that one. Give me just a second. It's going to be in the next little part, right after we do the uterus. Okay, so, and of course, pelvic inflammatory disease increases the likelihood of tubal pregnancies, right? Because if fertilization occurs and you block it, then it can't implant in the uterus. It quite often tries to implant in the tube. And just to be clear, those cannot be carried to term. They can't, and will probably kill the woman if she tries. Okay, so let's talk about the uterus. So if we get into the uterus specifically, the basics of the uterus, let's look at the parts, and then we'll look at it in a mid-sagittal section. This portion of the uterus is called the fundus, yeah? This is the body of the uterus. This is the narrowing portion right here is called the isthmus. Isthmus generally means a narrowing portion. And then this portion that projects into the vagina is called the cervix. The cervix is the baby holder inner. Because if you are pregnant and high levels of progesterone over long periods of time, it closes really tightly, and it also develops, ooh, this is sexy, a little mucus plug. It holds it up there, right? Now you're like, oh, this is the hottest lecture I've ever heard. No, mucus plugs. So you develop a little mucus. So that's the cervix. If you look at a mid-sagittal section, I want to make sure that you can find the uterus versus the urinary bladder. And I know it sounds like I'm talking to you like you're stupid, but I'm not, because I grade these tests every damn semester and people can't find a damn thing, okay? So what is this, guys? Urinary bladder. What's this? That's the uterus, okay? So how many holes you got? Well, it depends on whether you're male or female. You got 3 holes, right? So make sure you can find those as well. So that's the uterus. The uterus is anterior, right, to the rectum, and if the woman is not pregnant, it's going to sort of fold over the urinary bladder. The way to find it pretty dependably is to go up the vagina, and there it is, right? So it's hollow. It's really, really thick-walled. There's tons of smooth muscle in the wall, and it has a relatively small lumen unless the woman has been pregnant. If you have had a baby, it never goes back to its original size, but moms, nothing else does either. So it's not surprising, right? Nothing's ever the same after that. Okay, so it's about pear-sized in a woman who hasn't ever been pregnant, and it's bigger in a woman who has. So we can always tell postmortem if a woman has had a full-term or almost full-term pregnancy. You can tell by the size of the uterus. Okay, so as far as the supports of the uterus, let's look at those. We have, of course, the broad ligament. We have, oh, where's that picture? Let me find the other one. Okay. So we have the broad ligament that we already talked about, right? Okay. This ligament right here is weird. This one goes from up at the top of the uterus. This is called the round ligament, and it goes through the inguinal canal and attaches onto the labia majora. So out. Makes more sense in a man than it does in a woman, but it's just sort of wired up the same. And then we have the lateral cervical or cardinal ligaments, and those attach near, transverse cervical is what they call them here. These attach to sort of mostly the vagina, but the distal end right here. So all of these are sort of holding the uterus in position. And the other thing that holds the uterus in position is simply that you have a floor of skeletal muscles right here, right? Okay. There's skeletal muscles called the pubococcygeal muscles, and they're all forming the pelvic floor. And as long as those are intact, things kind of stay up there. So in addition to all the ligaments that you have up here, you also have this floor of skeletal muscles. Okay, so now let's look at the tissue layers inside. If you look at the tissue layers inside, you can kind of see what's going on. So the tissue layers of the whole thing. So if you look at the wall of the uterus, the outer portion of the uterus is called the perimetrium. And it's really just serous membrane. It's basically the visceral peritoneum. And then you've got a really, really thick layer of myometrium, and the myometrium is just the smooth muscle in the wall. And then the inner layer right here is called the endometrium. And the endometrium is multiple layers, one of which you keep all the time, and the other you build up and then slough off. Just hit myself in the face. Build up and then slough off. Build up and then slough off. Okay, so this layer right here, really, really vascular layer. Here's the myometrium, right? Just below it. This is the basal layer of the endometrium. You keep that one every time. Okay, what it has the capacity to do is every single cycle, it will go through cell division and make the functional layer, right? And then the functional layer will stay there as long as you have progesterone. And then if no implantation occurs, your progesterone drops, and then you slough off the functional layer. So I want to reiterate what I said before about you don't menstruate fluid, you menstruate tissue, really vascular tissue. You lose vascular tissue every single cycle. Does that make sense?
That's all you're not losing.
Well, I mean, it is blood. It is blood, right? Because it's vascular tissue, but you're actually losing tissue.
So at no point during your menstruation are you losing just blood.
No, you are not losing just blood. You are losing very vascular tissue. So if you looked at it under a microscope, it would have cells in it that were not blood cells, for instance, and blood cells. Yes? Does that make sense? So you're losing both every single time.
And why endometrium? Like we have pericardium for cardiac is heart.
I don't actually know. If you look it up, tell me. I don't know what that root means. I never thought to ask before. If you find out, tell me. So you get to keep this every single month, right? And then this one, build up, lose it, build up, lose it, build up, lose it. I wonder, I have wondered, like, why can't you just make one and just like let it sit there? But apparently it needs to be a fresh one every time. You got to have a new baby blanket every time, right? New baby blanket. Not that baby, right? So that's the functional layer. And then that one gets menstruated every single time. Okay, so we're about to get to endometriosis in just a second. Blood supply to the uterus, guys. Blood supply to the uterus is via the internal iliac arteries that have a branch called the uterine arteries, and that probably doesn't surprise you at all. And they run through the broad ligament right here, okay? Do you see these uterine blood vessels going to the uterus right there? Okay, all right. So I want to talk about endometriosis, not because I'm an expert on it and it is so freaking confusing, but because it is really, really important to understand. Okay, so with endometriosis, what happens is your endometrium in a healthy person, a healthy woman, should stay confined to the uterus, the lining of the uterus. But for reasons we do not understand, what happens in some women is the endometrium does not stay confined to the uterus. And every single month, under the presence of certain hormonal environments, the endometrium will start to grow. But instead of just growing inside the uterus, it will grow into the tubes, and it can leave the tubes and grow on your ovaries, on the outside of your uterus. It can even grow all the way up to your diaphragm. Okay? It is similar to a cancer with the exception of the fact that it respects the boundaries of the peritoneal cavity. It doesn't go past the peritoneal cavity, but it can grow all over the peritoneal cavity. And every single cycle, when a woman actually builds up her endometrium, it's going to grow all of those places. And then when the progesterone level drops, she's going to slough it off of all of those places. It is relatively uncomfortable when it sloughs off of here, but when it sloughs off of something that didn't expect for the tissue to be pulled off of its wall, it's really, really painful and can potentially cause scarring. The scarring associated with it sloughing off of the uterine tube causes infertility in many, many women. So I'll show you a picture of, this is healthy on the top, healthy uterus, healthy ovaries, and all of this is inflamed and irritated tissue because of endometriosis. So it's super duper painful. It's really difficult to get a handle on. Sometimes women choose a treatment in which hormonal treatment can sometimes help. So for instance, if you have a 14 or 15-year-old girl who has endometriosis, you can put her on birth control even if she's not sexually active, because it can sometimes help mitigate the symptoms. Sometimes pregnancy helps if you can get pregnant. Sometimes throwing the hormones out of whack will stop the progression of endometriosis, and sometimes it doesn't come back after pregnancy, but we really don't know, right? And sometimes women just eventually have to have a complete hysterectomy in order for it to go away. So it's a really, really high incidence of infertility with endometriosis. Does that make sense to you guys? And I wish that we knew more about it than we do, but we don't actually even know what causes one woman to get endometriosis when another woman doesn't. It doesn't have anything to do with sexual activity, because you can be just starting to menstruate, no sexual activity whatsoever, and get endometriosis. Doesn't have anything to do with that. Doesn't seem to have a very strong genetic component, although it does increase in likelihood if someone in your family has had it, but it's not like you inherit it either. So it's a bit of a mystery, and I don't know it. Okay, and then cervical cancer. Okay, so this is the one that I always try to read some new research to bring in every single time just because I think that I should. Cervical cancer is an interesting one. It is the third most common gynecological malignancy after breast and ovarian cancer, and it's the eighth leading cause of cancer-related deaths in women. But it is also the one that is really, really preventable with proper care. So I want to talk about what it is and then talk about Utah. Okay, so you guys know where the cervix is, yeah? The cervix is lined with epithelial tissue. For whatever the heck reason, this epithelial tissue has a relatively high incidence of cancer, but it's a really, really slow growing cancer compared to most cancers. It doesn't metastasize very quickly. So if you keep an eye on what is going on with the cervix, you can usually catch it in its precancerous stages versus its cancerous stages. Okay, so they usually do that by doing what we call a pap smear. And with the pap smear, what they're going to do is they're going to stick a little freaking brush up there. It is not comfortable. And they are going to scrape some cells off. And then somebody who paid attention in histology, a pathologist, is going to compare what the epithelial tissues look like on a healthy cervix to what they look like if they are abnormal, right? Can you see these nuclei are misbehaving over here, right? Okay. And this doesn't necessarily mean you have cervical cancer, but it increases the likelihood of cervical cancer, and they are going to need to watch it. You're going to have more frequent pap smears, right? And you might even need to have an ablation in which they pull the tissue off or freeze it or have surgical intervention or something. But if you catch it, you might very well not ever get a cancer diagnosis, because more than 50% of women who have cervical cancer have never had a pap smear. And the likelihood that you can catch it is pretty high when you go in early. So the reason I thought this was worth talking about is because most cervical cancers are associated with an asymptomatic, usually, STD called HPV, human papillomavirus. And human papillomavirus, there are several strains. There are more than just these. But it's usually associated with cervical cancer. And it's asymptomatic, so the person that you had sex with probably did not know that they had it. And you probably won't be symptomatic if you get exposed to it. But 10 or 15 years later, you will get an abnormal pap smear. And then you could, for instance, get cancer associated with it. And the reason I think it's worth talking about, because there are two strains of HPV, 16 and 18, that are responsible for upwards of 75% of cervical cancers, and also vaginal and vulvar cancers, and also some cancers of the mouth and throat. These two are usually likely to cause genital warts, anogenital warts, all really gross to think about. But here's the good part. The good part is that there is a vaccine that is really, really effective at preventing the most serious forms of HPV. Is it 100% effective? No, there isn't a vaccine that's 100% effective. The most likely name that you know of it is Gardasil. Gardasil used to only be available for girls, and then it was available for boys, and then it was just available for children, and then it was available for you up to age 27, and then just last year it got approved up to age 45. So you can get protected all of these ways, and this is really important for you guys to know because Utah has the lowest rate of HPV vaccination in the country. Okay, so this is important for a couple of reasons. So it doesn't just cause cervical cancer, and I know a lot of men say, I don't have a cervix, I don't need to get vaccinated. Well, A, you're probably going to have sex with someone who does, and B, it doesn't just cause cervical cancer. So 35% of HPV cancers are in the cervix, the rest are here. Mouth, throat, penile cancers, cervical, vaginal, all of those. And here's something that's interesting. This is from the Canadian Cancer Society, and this was just published last month. For reasons we don't understand yet, when men get these cancers associated with HPV, first of all, men are much more likely to get throat and mouth cancers associated with HPV, and they're much less likely to survive them. We do not know why, but they are very, very aggressive when men get them. And I was looking this up and trying to put it into my lecture last night. My 12-year-old's sitting next to me. We're just hanging out, and he's like, all right, I know what HPV is because I already got him vaccinated. I know what HPV is, but Mom, why do they have cancer on the junk? I get that part. And why is it on the mouth? I was like, oh, well. And he goes, Mom, are you telling me? I'm like, I'm not telling you anything. He's like, gross. Just walks off. It like literally had never occurred to him before, and he was shocked. I was like, it's fine, go play Minecraft. I wasn't going to tell you that at this particular moment. He was repulsed. And he actually said, he walked up and he goes, grown-ups are gross. Like, you're not wrong, sweetheart. So, I talked to my OBGYN about why we have such low vaccination rates, and his theory was, of course, that we have this sort of purity culture that says that you are only going to have sex once you're married, but he also wanted to acknowledge that everybody lies about sex. Like, it is just one of the things that you do, right? How many people have you been with in any sexual situation? Calculate, figure out what the answer they want, lie, right? Same as how much do you weigh? Calculate, figure out what answer would make me not look like a hippo, lie. Right? So you are not just dealing with your behavior, you're also dealing with others' behavior, and realize that this does not require intercourse. Yes, it doesn't require intercourse. And also realize that cancer is a big freaking deal, right? It's a big deal. He told me, and this was one of the saddest things that I had heard from him, and my doctor was a research doctor. I had a high-risk pregnancy, so he was a really, really smart dude. He told me that he has been most effective at getting his patients to consider vaccinating their children here in Utah by telling them that that they need to consider the possibility of sexual assault. I was like, you have to like talk about assault to get them to protect against cancer, which just like threw me for a loop. But he said that's how he ends up appealing to people, because you can't protect them if they're sexually assaulted. I'm like, all right, whatever works. But so anyway, that's Utah and HPV. Utah has a really, really, really high rate of HPV. Almost 70% of people who are sexually active in Utah have HPV. They don't necessarily have this strain. Go ahead.
So you said it's asymptomatic. HPV.
These two are usually asymptomatic. These two usually manifest with warts, but not equally in both sexes.
So you could go decades.
Yes, exactly. Yes, absolutely. Yeah. So your whatever sexual activity that got you exposed could have been an entirely different, less pure time of your life.
So what about, so that just the vaccine is not approved up to adults like till they're 45?
I think so. Yeah, 45.
What happens if you're already infected with HPV without knowing it, with it being asymptomatic, and then you go get the vaccine? Would it have any?
They don't actually know, but they don't think it's negative, right? So when a friend of mine went in, and she's 37, 38? And she went into her doctor. This was right before it was approved up to 35. And her doctor said, well, you've probably already been exposed to it, so don't get the vaccine. And then my darling friend chose not to and got this one. And then went back to her doctor, and her doctor told her, you have an 85% of getting chance of getting cervical cancer within the next 10 years. Because that's how serious those are. So don't know how protective it is. That's probably more protective than not. Go ahead.
So what if you had an ablation, like, do you still have a chance of getting?
Oh yeah. Mm-hmm. Yeah. If you had an ablation before, they're probably watching you even more carefully, right? Right? No, not for long. So they just continue to watch and see if it pops up. But again, I'm going to go ahead and tell you that as scary as this is a slow-growing cancer, and you can usually catch it in the precancerous stages, right? So we're not talking about like anytime anything's weird, you're going to die. We're talking about anytime anything's weird, you need lots and lots of care. And then with women especially, they're more likely to live through cervical cancer than not. The issue that I didn't know about, which was fascinating, is just that men are the ones who get the mouth and throat cancer. And I don't know why. They have not been living through it, that exposure. It's kind of tragic. So you guys should look this up if you're interested in it. Okay, so let's talk about the vagina. Vagina, okay. You can find it, right? Okay, I'll find it on a picture, okay? Everybody giggles, and now I'm going to tell you guys what you got on the vagina pictures after the test is over. Okay, so here's, of course, the vaginal orifice, right? And then you know where it is with reference to the urethra and with reference to the rectum. You can find all of those locations. Multiple functionalities. Of course, that's how you ovulate, right? The unfertilized ovum. It's also the birth canal. And it's also what receives the penis and the semen during intercourse. The basic portions of the vagina are pretty easy. This portion right here, that is the vagina as it sort of wraps around the cervix, is called the fornix. Little fornix. Apparently there's tons of sensory nerve endings up there. I don't know what the hell they're for because nobody gets up there, but there's a whole bunch of sensory nerve endings right around the cervix. And then the rugae of the vagina are the folds in the vagina, and this is what they look like. Here's the cervix, yeah? Here's the rugae. And the rugaes function sort of twofold, right? It needs to be able to stretch because the baby might be coming out of there. And of course, the folds increase stimulation on the penis and make ejaculation more likely. It's just increased friction, right? Okay, so as far as the tissue layers of the vagina, you guys probably remember that the vagina is lined with moist stratified squamous epithelium, right? And then there's going to be smooth muscle behind it. Does that sound familiar from the first part of the semester? Okay, the moist stratified squamous epithelium lining the vagina is a little different than that lining the mouth because it actually has secretory capacity. There are glands in it that cause it to secrete glycogen, which when it hits the lumen of the vagina, the glycogen is fermented, and the vagina always stays slightly acidic in a healthy woman. And the acidity is important. The acidity does a couple of different things. First of all, it's hostile to pathogens. So it's a protective mechanism. Second, the acidity will make the semen clot and stay in the vagina. The sperm keeps going, but the semen stays in the vagina, right? So this is inhospitable to most pathogens. Interestingly, though, some women, the secretions of their vagina are also inhospitable to some semen and sperm. So causes like fertility issues between people. Interestingly, this is like a protective mechanism in mammals. In mammals, first of all, someone that you're really closely related to usually like does not smell like yes to you. They smell like no. Like people tell you that your brother's hot and you're like, that's disgusting, shut up. But in addition, if in mammals sex occurs, it is usually not very hospitable to fertilization and implantation. So this is like a protective mechanism, which is interesting when it happens to two people who are not closely related, right? So my sister-in-law, one of my sisters-in-law, had a boyfriend for like 10 years. And every single time she had sex with him, her vagina, literally the whole damn thing sloughed off. And I'm like, I think evolution is trying to tell you something, don't you? And she's like, no. And I'm like, he's not even funny. I don't get it. I don't get it. And eventually they ended up breaking up. And I was like, that's good, because that would have been some kind of jacked up baby. That's the mucosa layer, the inner layer. Okay, so the opening, of course, the vagina is the vaginal orifice. And where are you, vaginal orifice? I lost it. Okay. I don't know why they didn't put this in your textbook, but here's the vaginal orifice. Okay. But what partially to completely covers the opening to the vaginal orifice before intercourse or before it's ruptured by some other mechanism is a flap of tissue called the hymen. I have no idea why they didn't put it in the textbook because it's not even controversial. And it's got both cultural significance and also some anatomical significance. So the hymen partially to completely covers the opening to the vagina, and here's just several different types of hymen that exist. So this is what a typical hymen looks like. They can be smaller, they can be larger, they can be almost completely intact. Like this one is an imperforate hymen. It's really microperforate. It's got tiny little holes in it, but it's usually relatively thick. This one and probably this one, these women, when they menstruated, they would probably menstruate 3 weeks out of their cycle because it would take that long to get rid of the tissue and then start the whole thing again. So this looks like it doesn't have any holes in it, but it actually has micro holes in it. Now, the reason this is worth talking about is because culturally, of course, the hymen has been significant in many, many cultures. Western European cultures historically, other cultures still, currently, the hymen is significant. It is very often considered evidence of the evidence that a woman has not had intercourse, okay? But just so you know, you can break the hymen by multiple different ways. You can break it by insertion of a tampon. Of course, you can break it by masturbation. You can break it by sports activities, especially if it was one of these relatively tiny ones, right? You can break it by a bunch of different activities. You can break it by riding a horse. You can break it by riding a bike. You can break it by falling on it, right? So it's not necessarily what it means, but historically speaking, it was culturally significant because it was evidence that a woman had not had sex. And in some cultures, it was necessary to deem a woman marriageable. And if her hymen was not intact and it would be inspected, then she was not considered marriageable. Still happened up until like Queen Elizabeth II was the Virgin Queen, wasn't she? Queen Elizabeth, I can't remember. I think that was Queen Elizabeth II. I can't remember which one. She was the Virgin Queen. She was never married. She was, of course, the monarch of arguably the most powerful nation in the world at the time. But she still, every single month, had to have her hymen inspected by the royal doctor, or else she had to give up the throne to make sure that she was still a virgin. They also used to, historically, in Western Europe, as evidence of a marriage well made, they would hang out the bloody sheet immediately after, because a lot of times when the hymen is broken, there's a little blood. So women were not stupid. Just to make sure, they would like carry little pig's blood, just in case, right? Because you didn't want to get hung or something, right? And then in other cultures now, still, the hymen has to be intact in order for the woman to consider to be considered marriageable. They do hymenoplasty here in the United States, which is if your hymen was broken for whatever reason, they will take some tissue from the inside of your mouth and they will sew it back up right there. And then you go back to wherever you were, let it heal, and then you're considered marriageable again. So the hymen is really kind of an interesting sort of cultural thing, and there is no analog to it in males, no evidence that a male has not been sexually active. Okay, so that's a hymen. Let's move on to the male reproductive system anatomy. Okay. When we do male reproductive system anatomy, just the basics, of course. Let's go through the basics. So, of course, we have the scrotum and the testes. That's what we're going to talk about first, okay, including the epididymis. We have the penis. We'll talk about that in just a second. And then we have all of these accessory glands and tubes that are primarily related to getting the ejaculate into the penis and out, including the bulbourethral glands, which we've talked about before, the prostate gland, right, and the seminal vesicles. So let's just talk about the scrotum first. All right, so the scrotum is homologous to what female structure? Labia majora, exactly. And the function of the scrotum is to protect the testes and also to temperature regulate the testes. Because spermatogenesis doesn't occur at normal body temperatures, the testes actually have to be cooler in order. Does that make sense to you? They have to be cooler in order for spermatogenesis to occur. So for instance, if a male has an undescended testis that didn't ever move through the inguinal canal, in all likelihood that one will not produce sperm. Does that make sense? Okay, so they drop from the abdominopelvic cavity through this inguinal canal, and they do that during development. Usually they drop before the baby is born. Sometimes they're still up there and you have to go get them, but usually they drop before the baby is born. There is a middle septum in here that separates the two halves of the scrotum. It's also called the raphe right there. And then there's two layers of muscle. The layer of muscle that's just deep to the skin right here is called the dartos muscle. That dartos muscle just kind of wrinkles the skin of the testes. This one right here is the cremaster muscle. That's actually an extension of the internal oblique muscles. It's skeletal muscle, and its primary job is to raise and lower the testes based on one of two things, usually temperature, like come home when it's cool, or also the sympathetic nervous system response. If you're scared, they also come home, right? So that's what these do, raise and lower the testes. So even though these are skeletal muscle, it doesn't mean you can like do tricks with them or anything. They're not completely voluntarily controlled. So that's the cremaster muscle. Okay, now let's look inside the testes, which are the male gonads. Okay, so if you look inside the testes, so we have done a section here of the testis. Here's the spermatic cord. There's the vas deferens. This little guy sitting on the top is the epididymis. Looks kind of like a mullet sitting on top of the testis. Do you see it? Okay. Inside the testis, do you see what looks like little orange slices? Yeah? Those are called lobules. Okay, but before we get all the way in, so the scrotum would be out here, right? Okay, then inside the scrotum, there's a double layered membrane. Very similar, it's actually a serous membrane. Do you see it, that two-layered one? There would be serous fluid in here. So they've got some lubrication around them. This is called the tunica vaginalis, but just because vagina means fold, so it's a really folded membrane, the tunica vaginalis, the folded coat. So here's the parietal layer, folds up, wraps around. This is the visceral layer. Serous fluid in between there, right? Okay. That's actually, by the way, an extension of the peritoneum, which is like continuous with the peritoneum and came out the inguinal canal with the testis when it left. Okay. All right. And then inside here, we're going to run into some connective tissue. This is the tunica albuginea. You had one in the ovaries as well. This one's way, way thicker. It is kind of like dense irregular connective tissue, and it's really, really thick because these things are under really high pressure. Inside each one of these lobules is a tube called a seminiferous tubule, and they are stuck in there. They're just like packed in there. Did you guys remember when golf balls were made of like rubber bands? They had just a whole bunch of rubber bands in them. If you cut them open, the rubber bands would just squirt out. Testes are the same way. These things are packed in there so tight that when you slice them open, the first time I did it, I got hit in the face with a seminiferous tubule, and now I always wear goggles every single time I do it. So because it's just so they're just packed in there really tight, and for that reason, they're really, really, really susceptible to pressure, and because you can pop them, right? So if they ever get any kind of blow, any kind of flick, any kind of anything, they're just going to like shut you down because you can pop one. Really good way to pop one of these is skateboarding, right? Probably know a skateboarder who's popped one, especially when they're sliding down rails. You're like, that is a bad plan. I don't know what you're doing. Are you wearing a cup? Because you should be wearing a cup. So inside these, each one has a seminiferous tubule. So I want to talk about the whole spermatogenesis thing. Seminiferous tubules, if you do a cross-section, that's where you do spermatogenesis. Basically, they are going to do spermatogenesis from the outside of the tube to the inside of the tube. In every single one of these 250 tubes per testis, they are going to be doing it along the whole length. So let me just show you how it works. Okay, so take this and we're going to blow that up. And here is the outer portion of the seminiferous tubule, and here's the lumen. Okay. So what's going to happen is all along the length of all of those tubes, all 500 tubes, what you are going to do is you're going to take these spermatogonia, what they're 46 chromosome cells, and they're going to go through meiosis, yeah? And they're going to go through meiosis to 23 chromosomes, and then you are going to dump the 23 into the lumen, right? Those are not ready yet. They're not baked yet. Their little tail doesn't wiggle yet, and they need a hat. But what's going to happen after that is they were made in here, and then let's just follow them. They are going to go from here to here. This is called the rete testis, sort of where they all come together. Okay. Then they're going to go out these efferent ductules, and then they are going to spend 20 days going from the head, the body, and the tail of the epididymis as they go through maturation. As they do that, their tail starts to wiggle. They put mitochondria and they start working their flagellum. And then they also get a little hat on called an acrosome. The acrosome has enzymes in it that allows it to burrow through the wall of the egg. Yeah? So, interestingly, that means that men actually do not ejaculate sperm from their testes. They have to ejaculate it from their epididymis because it's not done yet from here. It doesn't work. So 20 days going through here. 20 days for maturation. So head, body, and tail, and it actually goes from the tail of the epididymis into the vas deferens. Does that make sense? Okay. The acrosome, go ahead.
So how does that work? If you have sex
Frequently.
more than once every 20 days,
We don't ejaculate all of them. You have so many.
so they're being carried in like mucus.
Yeah, there's a fluid.
But mucus is not sperm. So, I mean,
No,
not-
here it's just fluid. They're basically just in fluid now. We haven't made semen yet. So they're just in a fluid that's unique to the epididymis, and they are maturing and moving through the fluid that's unique to the epididymis. And then once we add fluid or secretions from the seminal vesicles in the prostate and the bulbourethral, then you have semen. So here it's really just sperm in some kind of little fluid that they can swim in. Go ahead. Did I get you? No? So you don't ejaculate, although you do ejaculate maybe 350 million to 500 million sperm per ejaculate on average in a male. You have trillions and trillions in here, and they're all going through the maturation process and all sort of moving down. So you have way, way more than you ever need. Although, when people are having fertility problems, they do tell them don't have sex every day, right? Does that make sense? I don't know how they space it out. Does anybody know?
I think it's like every 2 to 3 days is the optimal.
2 to 3 days allows to maturation and filling up. I don't know. Okay, so that's the epididymis. That's where her sperm mature. One last little tidbit about this. We didn't talk about testosterone secretion, but I just want to tell you that these cells that are right here between the tubes, these are called interstitial cells or sometimes Leydig cells. Those are the cells that make testosterone. So the tube makes sperm and dumps it into the lumen. The cells between the tube make testosterone and dump it into the bloodstream. That make sense? And so then the testes have done their entire job. So as far as blood and nerve supplies to the testes, they are supplied by testicular arteries, which are the gonadals, right? And the gonadals branch from where? Abdominal aorta, yeah, exactly. And they're drained by the testicular veins. They have sympathetic and parasympathetic innervation. Of course, they have tons of sensory innervation. Tons of sensory innervation. Okay, so we'll talk about the epididymis, and then we'll do the whole path of semen in just a second. So the epididymis that we talked about is this little guy right here. If you stretched out the tubes of the epididymis, it has about 4 to 5 meters of tubes in it. And you are going through and maturing as you go through that entire thing. And you have smooth muscle in the wall of the tubes. When a male ejaculates, smooth muscle contraction starts from here, yes, to get it into the tube. And there's smooth muscle in the wall of the vas deferens, that contracts too. Smooth muscle in the walls of the ejaculatory duct and the glands, yes? And smooth muscle in the wall of the urethra as well. So the whole thing is going to contract during ejaculation. Does that make sense? Okay, so now let's talk about the vas deferens or the ductus deferens, because that's where we're going to go first. Here's the very first portion of the ductus deferens, which is actually attached to the epididymis, not the testes. And the path of the ductus deferens is weird, isn't it? Right? So here's the epididymis, right? Ductus deferens goes up through the inguinal canal and then wraps around the backside of the urinary bladder, right, to dump in with the seminal vesicle to the ejaculatory duct. So if you looked at a posterior view of the male reproductive tract, so this has to be posterior because you couldn't see the seminal vesicles if it was anterior, right? Okay, so this is a posterior view. Looks kind of like an angry mosquito to me. There's just angry eyebrows, and this is proboscis, right? So we're going to move up, and then we're going to dump in with the seminal vesicles into the ejaculatory duct, right? And then the ejaculatory duct is going to dump into the prostatic urethra, yeah? And then we already know the other parts of the urethra. Here's the membranous urethra, and here's the penile or spongy urethra. Smooth muscle all the way down to about here. All of that will contract during ejaculation. Everybody good? It's snowing, guys. It's pretty outside. Okay, so vasectomy. Let's briefly talk about what a vasectomy is. What a vasectomy is when a man decides he does not want to make any babies, he can choose to have his ductus deferens or vas deferens cut, cauterized, snipped, clipped, any combination of the things, and sometimes all of them are necessary because evolution definitely says there should be some sperm in there and it just keeps trying to grow back together. So what they do is they open up the spermatic cord, which has all the tubes in it, right, that goes through the inguinal canal. You open up the spermatic cord and you just move aside the testicular artery and testicular vein and the nerves. It's easy to tell the difference, right? You guys could probably do it at this point. Don't do it. But cut the ductus or vas deferens and then make sure that the damn things don't want to come back together, right? So a lot of times they will cut and cauterize, they will cut and clip, they will do any number of things to keep them from coming back together. And then you have to wait a little while before you have unprotected sex because there's still likely some sperm in the tubes there. And then you have to go back to the urologist and ejaculate to make sure that there's no sperm in your semen. So one of the things that a lot of people misunderstand is when a male has a vasectomy, he is still going to produce semen upon ejaculation. It just doesn't have about a couple milliliters of sperm in it, that's all. And nobody's going to notice that volume difference. It's still got all of the fluid from the seminal vesicles and all of the fluid from the bulbourethral glands and the prostate gland. It just doesn't have any sperm in it. Does that make sense? The volume change is negligible and most people would have no way of noticing the volume change. So, and it's outpatient surgery. And it's got about a 50% success rates in reversal. Tubal ligations are not very successful in reversing a tubal ligation in women. Okay, so the male urethra we already talked about, right? Let's just go back to the spermatic cord real quick. So this is the spermatic cord. All of this stuff had to move from here through the inguinal canal during maturation and development. And that means that in males, the inguinal canal is bigger than it is in females, which makes inguinal hernias more likely in males, yeah? If something happens up here that really, really increases the pressure, he's straining for something, picking up something heavy, a male is more likely to pop something through that hole than a female is. Now, a female has an inguinal canal, but really doesn't have much in it except a ligament and maybe a couple of tubes, but this one is relatively large. And if you pop something through it, it's called an inguinal hernia. Okay, penis. So as far as the penis portions, the root is the portion right back here that's sort of behind the body wall. This is, of course, the shaft, and this is the glands covered with the prepuce. Does that make sense? And then we'll look at the erectile tissues in just a second. So the root is continuous. Let me show you this picture. So here's the root back here, right? This is the crus, or plural is crura. Remember that we had those with the clitoris as well. So this is the portion that's kind of behind the body wall, right? And so since that's behind the body wall, when it starts to fill up with blood, the crus and the crura will allow for the penis to stand up, right? So it's like our pool float metaphor that we used before, right? So you've got part of the pool float stuck against the wall, and then you start filling it up, not with air, but with blood, right? And then it stands up. So root of the penis, body of the penis, and then glands of the penis. So before we go any further, let's talk about circumcision, what the penis looks like in its original factory setting, and then circumcision. So men are born with a prepuce that partially or completely covers an erect penis. And this prepuce, of course, has functionality. It's similar in functionality to the prepuce of the clitoris. It sort of protects the glands of the penis. And it protects the glands of the penis, and there is argument about this, and you guys can, if you want to argue with anybody online, there's plenty of people to do it with, and they love to argue about circumcision. So with circumcision in men, what it is they remove the prepuce of the penis. Historically, it's got some cultural significance, right? Like religion and cultural significance. And historically, it helped to keep the glands of the penis clean. But so does proper hygiene, which can totally be taught. The inner surface of the prepuce has glandular tissue that actually produces a waxy secretion called smegma. That's where that word comes from. And if you do not clean that properly, it's more hospitable to urinary tract infections and STDs and STIs. But if you do clean it properly, then it's not. So hygiene can take care of all of this, right? And we, of course, have access to running water and hygiene and all of that kind of stuff. So big argument is going on. In the United States, in this particular culture, circumcision is still more common than not circumcision. But even within the United States, it's like little mini cultures have different preferences. But it's definitely not that common worldwide. It is not most common to circumcise worldwide. It is least common to circumcise worldwide. So 60% of US males are circumcised. Last time I looked, I haven't looked this year. But it is becoming less common because people are arguing about whether it's medically necessary. It's not medically necessary. For that reason, the American Association of Pediatrics no longer recommends it. Some insurance companies no longer cover it. And just so you know, there is the argument that if you remove a covering, and this is a really, really sensory area, and you remove the covering long before someone becomes sexually active, how much reduction in sensitivity have you generated by the time he becomes sexually active? If that doesn't make sense to women, think about having the glands of your clitoris removed and having it rub against your clothes constantly for your entire life, and the reduction in sensitivity that would be likely. So people are arguing about it. And so let's think about the medical things. Does it reduce the probability of penile cancer? Does it reduce the probability of certain STDs or STIs and urinary tract infections? And the answer is yes, but so does proper hygiene, with one exception. And the one exception that seems to be that if males are exposed to HIV, they're less likely to contract HIV if they are circumcised. And that's the one exception. Okay, so, and those of us, has anybody seen it done? It's not something that I feel particularly good about having done. A lot of times they don't do anesthetic to the little boys, and it's pretty scarring. I'm pretty sure I owe him a car. Pretty sure I do. So yeah, it's a difficult one. Okay, internal anatomy of the penis. How does this all work, and how do erections work? We'll do it here because we're going to talk about, internal anatomy. So if you look at the internal anatomy of the penis, first, we have 3 erectile bodies, right? We have these 2, which are the paired corpora cavernosa, which are continuous with the crus or crura, okay? And then we have this one, which is the corpus spongiosum. So if you look at this picture, cross-section of the penis looks like kind of like a monkey face, right? Corpora cavernosa, corpus spongiosum, or, of course, it looks like our friend Kanye. We can appreciate that. Okay, so go ahead.
Is corpus spongiosum just the singular?
Yeah, it's just, there's only one. Yeah, because that's the one that surrounds the urethra. The function, by the way, of the corpus spongiosum, from what I understand and have been taught, is because if you didn't have erectile tissue around the urethra and you had erectile tissue here, then your urethra would be compressed, right? During erection, does that make sense? So the erectile tissue around the urethra helps to keep the urethra open during erection. Does that make sense? So it's erectile that way. It doesn't allow for compression in, erectile that way. Otherwise, you couldn't ejaculate. Okay, so here's how this works. Basically, you have these central arteries, and then this stuff, so stick with me for a second. I want to show you how erections work. This stuff right here is all, these are venous spaces. And then the tissue around here, guys, this tissue, the tunica albuginea in the penis is not stretchy. So here's what happens. When a male becomes aroused, you increase blood flow to the penis via the arteries, but at the same time you increase blood flow to the penis, you actually compress the venous spaces against not stretchy connective tissue. So you've got blood coming in that can't come out. That make sense? More blood in than can get out. And then what happens is your pool float stands up, right? That's the nature of an erection. It's not the nature of an erection in every organism, but it is in humans. We do not have a bone in our penis, but some mammals do. And lots of people still think that there is a bone in their penis, and we don't have a bone in our penis. So raccoons do, whales do, lots of different kinds of animals do, but you don't, right? You probably would have noticed by now if there was bone in there, I'd imagine, right? But there isn't. So this is basically just hydraulics, right? Just blow the thing up, right? And it's generally going to stay there unless and until the male ejaculates and the blood flow to stops. And as soon as you stop having more blood flow in, then you're no longer compressing the veins, and then you get more blood flow out. Does that make sense? Oh, that was me. My kid always turns that thing on. Now, each erectile body is basically delivered blood by that central artery, and then it smashes into the venous spaces. The blood vessels to the penis are from the internal, and then there's also a branch from the external iliac arteries, and the innervation is from the pudendal nerve. Okay, so now let's do the components of semen. We'll do the components of semen, and then we'll compare male and female sexual responses. All right, so with the components of semen, you've got to get all of the stuff in there, or else you are not going to have functional semen and therefore functional sperm. So we already know some of it. Of course, the sperm is coming from the epididymis up through the vas deferens, right? But then you have to add components from the seminal vesicles, right? The seminal vesicles actually make about 60% of the components of semen. And there's some interesting stuff in there that the seminal vesicles make. So seminal vesicles, by the way, have smooth muscle in their wall, and they will contract upon ejaculation. And then they have fluid. The seminal fluid has fructose in it. Fructose is sperm's favorite nutrient. So a little fruit sugar for the sperm. They've also got prostaglandins in them that cause cervical dilation. Isn't that interesting? Cause cervical dilation. They also have immunosuppressant chemicals that suppress the woman's immune system so that the sperm is more likely to get past her vagina. But it also makes it more likely that if he has an STI, she's going to get one, because there's an immunosuppressant chemical in there. There's also some enzymes in there, and then there are, interestingly, I don't know what this is for functionally, but I know that it's interesting in forensic situations. So there's a yellow pigment in the seminal fluid that fluoresces under certain wavelengths. So, and I know this because when I was in college, I worked at a DNA fingerprinting lab, and most of our cases, did I already tell you guys this? Most of our cases were from paternity cases, rape cases, and murder cases. That's mostly what we did, the DNA. But then every once in a while, somebody would just come in off the street and bring us his wife's panties and say, is there sperm on here? And I'll say, well, I can't test for sperm, but I can test for semen. And he's like, all right, that's fine. And then I would just literally take it to the back room and shine a light on it and charge him $250 because it fluoresces under UV light. Semen fluoresces under UV light. And then, of course, the next question he would ask me would be, is it mine? And I'm like, well, that's another $750, and it's going to take me about a week and a half, and maybe you should just go ask her. I don't know. Maybe. I don't know what you should do. So, yeah, it fluoresces under UV light. Don't ever watch one of those 2020 specials about them shining the UV light all over the hotel room. Oh, my God. I don't even know how it got up onto the ceiling fan. What the hell? What is happening here? Okay. Prostate gland is here. Yes? Prostate, oh, I forgot to tell you. Did I put it in here? There's also a chemical that comes from the seminal vesicles that will force ovulation. If the woman is about to ovulate, but she hasn't yet, one of the seminal vesicle fluids will actually make it more likely that she will ovulate. It's a little arms race right in there. You're like, I don't want to get pregnant. I want you to get pregnant. Okay, prostate gland. Prostate gland is here, wraps around the urethra, of course. It's got secretory cells and smooth muscle in it. It makes about 1/3 of the volume of semen. Please note that we are up to 90% of the volume of semen without even the sperm in it, right? And it makes a cloudy, milky fluid. It's got citric acid in it. Sperm likes the acidity. It's got an antibiotic chemical that combats UTIs in males, not in females. It's got enzymes that enhance sperm motility, and it's got enzymes that do this. What should happen is your semen should make it into the vagina as a liquid, right, all the way into the vagina, but then as soon as it hits the acidity of the vagina, it's supposed to clot. And then the only thing that swims is sperm. So it gets it all, everything that it needs to get to that point, and then sperm is the only thing that goes past the cervix. So get all the way into the vagina and then stay behind. Basically, you're like, I did everything I could for you. It's all you now, buddy. And then the sperm goes swimming past the cervix all the way up to the fallopian tubes. Okay, the prostate gland is really susceptible to inflammation, to infection, and you can have prostatic hyperplasia, and it makes it hard to pee. It's also a really common site of cancer in males, so that's why they do those prostate exams. Oh, that's fun, huh? If you're the way they do prostate exam, there's two possibilities and neither of them looks very pleasant. You could go up the urethra to see what the prostate was doing. Ouch. Or you could go up the anus just to feel, to see whether it was inflamed. Yeah, that's how they do prostate exams. You too, gentlemen, will have one at some point. Okay, and then of course what also ends up in the semen is the secretions from the bulbourethral glands. Those were produced before ejaculation, but they end up in the ejaculate, right? And that's just the lubricating fluid. All right, so last thing to do is to talk about a comparison of the male and female sexual responses, okay? So your textbook doesn't have anything about the female sexual response in it. And it's not because it's mysterious. I talked to Valerie O'Loughlin, who's one of the authors of your textbook, because we're in the same society together. And I'm like, hook some sisters up, Valerie. And she's like, nobody has it in the anatomy book. And I was like, well, you should have it in your anatomy book. So they've got all of the phases of the male sexual response and nothing, crickets, for the female sexual response. But interestingly, of course, there's a lot of parallels because they're homologous structures, most of them. So you wouldn't be surprised that there's a lot of similarities. So here's what we're going to do. We're going to do some comparison contrasts and figure out what's the same and what's different in males and females. Okay, so first off, arousal and plateau stages. These are the times in which a male or female becomes aroused, everything up to climax. Okay, so this is highly variable in its length. So in both sexes, what happens during the arousal and plateau stages is the nipples become erect and you get what's called the sex flush. The sex flush increases blood flow to your face and dilates your pupils, right? So your cheeks look rosy, your pupils get dilated, and your lips get swollen. If you manipulate the face of a woman in a photo so that she looks like she has the sex flush, almost universally heterosexual males will find her more attractive. Women do not care about the sex flush. It doesn't seem to make any difference in their perception of attractiveness. So other things that happen are your heart rate goes up, your blood pressure goes up, your muscle tone increases, and you hyperventilate. Not hyperventilate to the point you're going to pass out, just breathe faster, right? Okay, and then female versus male, what's different? In a female, you get an erection of the bulbs of the vestibule. Those are the ones that tighten the opening to the vagina. And you get increased blood flow to the labia majora. The glands and the corpora cavernosa of the clitoris, right? They go into the clitoris. Those will swell to 2 to 3 times their size, and the clitoris can stand up or change positions. The breasts will also swell. The lower 1/3 of the vagina constricts, and it's not just because of the bulbs of the vestibule, it's also because of muscular contraction in the walls of the vagina. So when a woman is aroused, the vagina is actually tighter. And then the uterus changes position, and this one's kind of interesting to me. So when a woman is aroused, even though I don't know how they discovered this before they did those internal structures with women who were actually aroused, the uterus is usually folded over the urinary bladder. When a woman is aroused, it stands up. So just hold on to that thought for just a second. Okay, the vagina becomes reddened, it becomes moistened because the greater vestibular glands will lubricate the opening of the vagina. And then in males, of course, we know how erections work. You get erection, you get increased blood flow in, decreased blood flow out. This is a parasympathetic nervous system response. In order for a male to have an erection, and a female too, although we don't know as much about females, you need parasympathetic nervous system response, not sympathetic. Sympathetic decreases blood flow to the penis and to the clitoris, okay? So this is how this works. We already talked about it. The blood flow to the penis during an erection and arousal is about 6 times above the normal blood flow to the penis. So you get 6 times more blood. Okay, so this will progress until the sheath of the penis, the tunica albuginea, which isn't stretchy. So what limits the size of the male erection is the size of the tunica albuginea. So once you get this as full as it can be, the tunica albuginea doesn't stretch anymore, and that's as big as it's going to get. It's just that's the limits of its expansion. So the tunica albuginea is right here. This connective tissue in here, this limits the size of the erect penis. Okay, so the erection will fade when the arterioles leading to the penis constrict, and you get less blood flow in than blood flow out, and you stop compressing the veins. The loss of erection can be due to ejaculation, or it can be due to loss of stimulation, or it can be due to sympathetic nervous system, right? If you get really stressed out, it's inhospitable to erections, right? If you get scared, if you get hurt, if you get almost anything, it's usually inhospitable to maintaining an erection. So with erectile dysfunction, what is that? Erectile dysfunction is the inability to achieve or maintain an erection. It was once thought to be always psychological because it gets all wound up with the sympathetic nervous system, because most of the time, 70% of cases start with something physical, right? Could be as much as hypertension or arterial sclerosis. But then, if something physical makes it less likely that you have an erection, then don't you activate your sympathetic nervous system because of the fear, the anxiety associated with that, right? So when something physical occurs, then what happens is the psychological piles on top of the physical. And so it's a little difficult to tease the two apart. But erectile dysfunction can happen and not happen at different points in your life, especially due to stress. It affects 2% of men under age 35, 10% by age 55, and about 50% by age 75. But it's more likely to happen at times in your life in which things are really difficult because sympathetic nervous system response. Okay, so of course also the bulbourethral glands will secrete the fluid when a male is aroused. All right, so what causes erections? What are the things that could cause an erection? Well, you're not going to be surprised by any of this. Conscious thoughts. Thinking of something amazing, seeing something amazing. Cerebral cortex can cause an erection, right? But also REM sleep several times during the night. We have no idea why erections tend to occur in males. A spinal reflex from touching the penis. This simply says that if somebody touches your penis and you like it, a spinal reflex will cause more blood flow to the penis. That's it, okay? But the brain can override the spinal reflex. Any kind of fear of failure, anxiety, pain, any of that kind of stuff can activate the sympathetic nervous system, which decreases blood flow to the penis. So the last stage is the climax stage. So what happens during the climax stage? It's the same in both sexes at first. The sex flush will continue. The skeletal muscle and the perineum, the pubococcygeal muscles around the base will contract. And the brain, most of a climax is actually in your brain. You think it's in your junk, but the reason it's pleasurable is because it releases all of your favorite neurotransmitters and neurohormones, including endorphins that make you feel 10 foot tall and bulletproof and also decrease pain. Those are pain relievers. Dopamine, which is your favorite neurotransmitter, which is your reward neurotransmitter, and a combination of oxytocin and vasopressin. Oxytocin is a bonding chemical that makes you feel close to the people that you have sex with. Vasopressin is a different kind of bonding chemical. It tends to increase territoriality and jealousy, but it does not necessarily at the moment. Okay, so what happens with a female during the climax stage? Well, remember how the cervix was in that weird position? What's going to happen is when a woman climaxes, the cervix, which was standing up, is now going to plunge into the vagina. Yeah? What do you think that's for? Yeah, it pulls up the sperm. Women who climax are more fertile than women who don't. But of course you don't need to, otherwise no one would ever have a pregnancy from a rape, right? Okay, so it plunges in and pulls up. In addition, you have involuntary pelvic thrusting in the female. If female ejaculation occurs in a woman, it is usually because of stimulation of this Grafenberg spot, and the fluid will come out of the distal end of the urethra. They tested it, doesn't have a whole lot of urea in it, has a whole lot of PSA, which is prostate-specific antigen, which tells you that it's probably something very different than what you thought it was, but it does come out of the distal end of the urethra. Okay, and in women, the brain releases more oxytocin than vasopressin. Oxytocin is pair bonding. Sex in mammals for the female is risky because pregnancy is risky and it's also resource intensive. So we tend to bond to the person that we have sex with because evolutionarily it's hard to do that stuff by yourself. Okay, so keep that in mind. I'm going to finish this. You guys can leave if you want to. So in males, of course, the climax stage is characterized by ejaculation, and you've got rhythmic contraction in all of the tubes and all of the glands. Okay, In males, vasopressin is released in higher concentration than oxytocin. Vasopressin, interestingly, does not cause the same kind of pair bonding. It's not the snuggly, you're my boo kind of pair bonding. It's the, this is my territory, not that's my boo, but that's my bitch. Because is sex as risky for the male in mammals? It's not, right? And you could definitely do that post-sex part easily by yourself. However, if you were going to raise a baby, whose baby do you want it to be? Yours. So it increases territoriality. It tends to increase male-male aggression. Isn't that interesting? So both sexes release both, but males release more vasopressin and females release more oxytocin. Okay, and then last but not least, the refractory period. The refractory period is after one climax, how long is it until you can have another climax? It doesn't exist in women. There is no physiological refractory period. Women can have back-to-back-to-back-to-back-to-back-to-back climaxes, at least physiologically. I'm not saying that you know how to do it, but there is no physiological impediment to doing it. In males, however, the refractory period does exist, and it lasts between minutes and days. Probably minutes when you're 14 and days when you're 85, really, right? And then the resolution stage, and then we're done. Both sexes in the resolution stage characterized by profound relaxation. You release a whole bunch of a neurotransmitter called GABA, and GABA is your super duper chill out neurotransmitter. And the genital tissues, the heart rate, the blood pressure, the breathing, the muscle tone all return to normal. The uterus drops back into its resting position, and the male loses its erection. There you go. All done. Don't forget your quiz. Okay? I don't remember when it's due, but you can look.